Welcome to the American College of Surgeons Bulletin Brief from the front lines, Surgeons' Voices. With me today is Dr. Jeff Matthews. Dr. Matthews is the professor and Dallas B. Phemister Chair, Surgeon-in-Chief at the University of Chicago Medical School. Welcome, Jeff.
Nice to be with you, Steve.
Thanks very much for being with us today. You have really led the way in terms of critical investigation of how we care for our patients and how we care for ourselves in terms of work assignments, as well as how we care for our residents for education during COVID-19. You've published extensively, you've created or co-created the MENTS system. You've done an incredible amount of work, and I'd like to try and distill some of that very important work down into our interview today. Perhaps you could start out by telling us what drove the MENT system to be created and how have you used it since its inception?
It's a great question. If I take us back to sort of January and February, as we stood up our hospital incident command center here in Chicago, and we were looking to see how the pandemic was going to impact us. Actually, Chicago was one of the first places in the United States where cases of COVID were documented and reported. But we saw what was happening, particularly in New York, with the hospitals being overrun and not really knowing what we were going to see in Chicago. We started to do some thinking about this in a planning kind of way, prospectively, before the onslaught happened to us here in March and in April. And one of the things that was, as you recall, the issue there was the increasing call for a moratorium on so-called elective surgery. But we certainly didn't have any sense as to what elective surgery meant, and there was really no guidelines on to how to think about what types of surgery should proceed and what types of surgery shouldn't. And back in those days, we were, those days seem so long ago now, but it was really just six months or so ago. We had to try to figure out if our operating rooms were going to need to be closed, or at least the surgical volumes were going to need to be reduced. How do we do that in an ethical fashion and in a way that was appropriate for patient care? And this posed questions for us that we never had to ask as a surgical community. This, for the first time, we were looking at resource shortages and resource allocation issues, whether it was in surgical critical care beds or hospital beds, the availability of ventilators, the availability of PPE, and lots of unknowns about how COVID would impact us in Chicago versus other cities in the United States and the whole time frame for this. So we set our surgeons out, and led by Vivek Prashant in our department here, we created an approach that considered the issues of resources that would be needed for a particular critical case, the issues around risk to the patient, risk of delay, risk of contracting COVID, or risk of spreading COVID, and factors related to the disease that we were treating and whether there would be alternatives to surgery, and try to put that into a framework that would work across surgical specialties to say that if we have to ramp down 10%, 20%, 30% of our volume, which cases were the safest to defer first, and how would that work? So that's where the idea came across, where we developed something that we called, rather than thinking about elective surgery, because I'm not sure what that even means, we talked about medically necessary time-sensitive procedures, and that's where the MENTS abbreviation came in. And that framework really helped us think about how to ethically triage in a way that cut across surgical specialties and seemed appropriate for patient care. The paper that we published got rapidly picked up by the American College of Surgeons, published in the Journal of the American College of Surgeons, and was rapidly endorsed by the American Hospital Association and the AORN and the anesthesia groups. And I think was widely adopted, not as the definitive word on how to do this, but as a framework, at least to hold these discussions in local settings.
Yeah, indeed. Not only did the JACS Journal publish it, but at the American College of Surgeons at that time it was called ACS COVID-19 Bulletin rather than Bulletin Brief. We endorsed it and we had a link to it, and we thought it was very, very clever and very easy to use. But perhaps for people not familiar, you could give us just a little thumbnail sketch of some of the ingredients, how to show how easy it is to use it.
Yeah, so this is basically a three-part approach where each factor, the patient's disease, the patient's resource consumption, the patient's risk, could all be factored together with a number of different criteria that were then scored essentially. And depending upon the score, the higher the score, the more resources would be consumed, the more a risk might be posed to both the patient or to the providers for proceeding with surgery. And there would be, potentially other alternatives other than surgery that could be used to make the decision. And so you basically would come up with a score that, ranged from, I think, 35 to, or 25 to 100 or something, that would then allow you to sort of scale and compare other cases to it. And you could then set a cutoff for what your OR was capable of doing. Back in April, we were only able to do about 10% of our usual volume. So only the highest priority cases by the MENT score would be used.
Well, we'll make sure that people can get directed to that publication, indeed, showing them the link. To switch gears slightly, you mentioned the word resources, and there certainly are the material resources, the PPE and the like, but there's also human resources. And what are some of the lessons learned during that March, April timeframe, which we may sadly need to apply again going forward as we hit potentially another winter spike in COVID-19 cases?
Yeah, well, we're certainly seeing that spike happen here in Chicago and elsewhere across the United States. The resources issue is also the team. And I think one of the most important things that we've had is how to keep the team safe from COVID and how to do appropriate contact tracing. We've been doing cohorts of teams that are off and then on to sort of protect the whole team. Everybody's at work now, every day, but we're finding increasing community exposures that are affecting our healthcare workers. So whether it's the availability of OR nurses or operating technicians or central supply individuals, those are some of the constraints that we're having now. But I think the other big thing that we need to address is the wellness of our teams more broadly, and the ability of our teams to sort of weather the storm. We're hearing the term increasingly referred to as COVID fatigue, where our teams that have been stressed out for 6 months now, seeing another wave in front of us, are really can struggle with the psychological distress of seeing more and more patients with COVID, patients on ventilators, and these sorts of things. So these are big issues we have to address.
Absolutely agree. Wellness is critical. One group for whom wellness is highlighted certainly are the residents and fellows, the trainees. They may be more attuned to it than some of us who've been out longer. And it is important. And how do we get into this issue for residents, fellows? You can even comment on medical students, perhaps some programs you've implemented, or some ways you have to detect if things need to change for your learners?
Well, it's a very interesting challenge, and it's something that the college, through the Academy of Master Surgical Educators, is addressing, as you know, is the broad impact on surgical education. We looked at it as just one program, as one department, and actually our residents put together a very nice summary of how our program responded and reacted. It mirrors what a lot of programs across the country had to do. And the key word was nimbleness, was being able to be flexible and adaptive to the changes that we needed to make. It's different what would happen in an institution where the services were completely overrun by COVID patients in the hospital, and surgical education was really in a back seat, versus what most places experienced was something more in the middle, where it wasn't business as usual, but things weren't completely disrupted either. But the issue there of how to of nimbleness, reorganizing teams, reorganizing service, and reorganizing the educational programs. I mean, it's amazing how we've all gone to these Zoom conferences and actually increased attendance in many of our educational activities, and all sorts of new things that we needed to learn. I think the second term that's important in the program's response is this issue of wellness. And we instituted that very early with check-ins, virtual check-ins, virtual sort of happy hours and programs, but also times when we could get together to discuss some of the difficult ethical challenges that we saw in dealing with patients at the height of COVID. So we instituted twice weekly ethics rounds to discuss about problems of informed consent in patients during a pandemic, and how clinical trials should or should not proceed during a pandemic. And then simple things in wellness like getting food to everybody, and as faculty finding ways to support our residents. And the third issue that was really important was communication. That's an absolutely critical component of that. So frequent updates, this is, as they say, this pandemic didn't come with a playbook. And so we were learning in real time, how to do testing and how to do proper PPE and what precautions to be taking. And we needed to continually communicate with our teams, and particularly our learners. And that meant also getting their feedback and learning how to empower the residents to make suggestions about how teams would be reorganized or how educational programs would be reorganized during a pandemic. So nimbleness, wellness, and good communication is sort of at the core of the response of an individual program.
Thanks. Absolutely key points, very essential for all of us, and we can learn some lessons from you. I like the check-ins. I think that's a great way to be proactive before there are problems rather than reactive after there are problems. So one final question. We've learned a lot during the last 8 months or so with COVID-19. Eventually, at some point, we're going to resume travel and going to meetings and having interviews, site visits and the like, board exams. Which of the facets do you think that have been our changes in practice? You mentioned conferences, for example. Which of these practices would you like to see remain behind when we go back to business as usual, if it's even business as usual in a complete sense?
It's a great question, because I think, as they say, it's hard to make predictions, especially about the future. But I think one thing that we can know for sure is that the implementation of video learning, video education, has been very positive. And it's going to, if even just look at the great success of the Clinical Congress of the American College of Surgeons this year, with record numbers of virtual attendees. So the ability to do these hybrid in-person, but also being open to the world is going to happen. And I think it's going to really transform the way we create networks of colleagues, the way we do collaborative work, and the way we gather together. So I think that's really important. I think there's one thing that is really, I hope, stays. What we've learned is that a lot of what we can do to be effective as care providers, as learners, as academicians, and as colleagues can be done virtually. And so this need to always be in the hospital is going to change. I think we've always struggled in surgery by this concept of presenteeism, that you have to be there. Physically there all the time. But I think there's going to be ways that allow us to actually be home a little bit more often and not have to be there, and a little more flexibility in our schedule. We talk about, work-life balance, work-life integration being a very important element. And I think the way we've seen that how our departments and how our trainees and how we can get our work done has been enhanced by bringing in the virtual formats. And so I think we're going to be a little bit more comfortable with people being at home and not being ashamed to say, hey, I'm at home. They can still participate and be involved at the same time. So I think that's going to be a really good benefit of all of this once we're past the crisis.
Well, as always, those are excellent insights that you shared with us. Any additional parting comments before we close?
I would say that we're going to look back on this pandemic as a once in a lifetime sort of transformative kind of disruptive event, and I think usually innovation thrives during this kind of disruption, and we're seeing that. I think we'll look back on this year that was, in many respects, a really horrible year in so many different ways, and we're going to see the good that came out of it and the impact that it's had on all components of our mission, our clinical care, our scholarship, and our educational programs. And I think we're going to be really pleased at how the surgical community responded and what we've learned, and how far we've been able to move our field forward.
Well, you've certainly been absolutely instrumental in helping to move the field forward. And it's my pleasure today to have spoken with you about some of the innovation which you brought to us to help the cause on a global scale. So thanks for everything you've done, and thanks for your time today.
Nice to be with you, Steve.